CICU devices.
Intra-Aortic Balloon Pump, indications, contraindications, and off-label use. The intra-aortic balloon pump is a classical form of temporary mechanical circulatory support. Introduced in the late 1960s, it remains one of the oldest and most extensively studied cardiac assist devices. It is designed to assist the failing heart by improving coronary perfusion and reducing left ventricular workload. The system consists of a balloon mounted on a catheter, positioned within the descending thoracic aorta. It operates through the principle of counterpulsation, inflating during diastole and deflating just before systole. During diastolic inflation, the balloon displaces blood toward the coronary arteries, increasing diastolic pressure and myocardial oxygen supply. Conversely, rapid deflation before systole reduces aortic end diastolic pressure and lowers afterload, thereby decreasing myocardial oxygen demand and facilitating left ventricular ejection. Historically, the Iabp was considered the first-line device for cardiogenic shock and high-risk ischemic syndromes. However, its role has changed significantly over the last decade. Following the results of the Iabp Shock 2 trial and subsequent meta-analyses, which failed to demonstrate a survival benefit in acute myocardial infarction with cardiogenic shock, the routine use of Iabp in this setting has markedly declined. Despite this, the Iabp continues to play a valuable role in specific clinical contexts. Additionally, it remains a practical option in resource-limited settings, or where more advanced mechanical circulatory support devices, such as Impella or ventricular arterial ECMO, are unavailable or contraindicated. The principal indication for intra-aortic balloon pump therapy is cardiogenic shock, particularly secondary to acute coronary syndrome, where the device serves as a bridge to recovery, revascularization, or definitive support. Iabp can increase diastolic coronary flow and reduce myocardial oxygen consumption, thereby improving the balance between oxygen supply and demand in the ischemic myocardium. The Iabp also reduces left ventricular afterload and increases stroke volume. It is also indicated in mechanical complications of myocardial infarction, such as acute mitral regurgitation due to papillary muscle rupture, where it reduces afterload and regurgitant volume and can stabilize the patient before surgery, or ventricular septal rupture, where it can reduce the left to right shunt volume, serving as a bridge to definitive intervention. The intra-aortic balloon pump may also be employed in cases of unstable angina or refractory ischemia unresponsive to optimal pharmacologic therapy, where diastolic augmentation can enhance coronary perfusion and provide hemodynamic stabilization while awaiting definitive revascularization, with percutaneous coronary intervention or coronary artery bypass graft. Similarly, it may be beneficial in high-risk percutaneous coronary intervention where transient hemodynamic instability is anticipated, such as in complex left main or multivessel disease, or in patients with severely reduced left ventricular ejection fraction. In the postoperative setting, the Iabp can be used to support patients with low cardiac output syndrome following cardiac surgery, especially after coronary artery bypass grafting, valve replacement, or combined procedures, where transient myocardial stunning or graft occlusion is suspected. Other Iabp indication is the acute heart failure with shock, especially when end organ perfusion is threatened and pharmacological therapy is inadequate or contraindicated. The device may also be used as a bridge to durable mechanical support or heart transplantation in cases of advanced heart failure, where other forms of temporary support are not available or not technically feasible. Additionally, less frequent indications include acute myocarditis, peripartum cardiomyopathy, cardiac graft rejection, or myocardial contusion. Finally, intra-aortic balloon pump can be also used in cases of ischemia-related ventricular tachycardia or fibrillation resistant to medical and electrical therapy, as Iabp deployment can optimize coronary perfusion and afterload, improving hemodynamic stability before ablation or revascularization. Regarding the contraindications, several clinical situations preclude the safe use of the intra-aortic balloon pump. They include severe aortic regurgitation, as balloon inflation during diastole would worsen regurgitant volume and increase left ventricular and diastolic pressure, negating the benefits of the device. Another absolute contraindication is aortic dissection, because balloon inflation can propagate the dissection flap or cause rupture. Aortic aneurysm involving the descending aorta is considered a contraindication too, due to the risk of rupture or embolization during balloon operation. Severe peripheral arterial disease, or aortoiliac occlusive disease, precluding safe insertion and maintenance of the balloon catheter, represents another contraindication. There are several off-label uses of the intra-aortic balloon pump that are not included among the approved indications established by the relevant regulatory agencies. In these situations, a detailed informed consent must be obtained from the patient, and special attention should be paid to the potential occurrence of adverse events. In recent years, the axillary insertion of the intra-aortic balloon pump has gained renewed interest among clinicians managing patients with advanced heart failure, mainly in the treatment of those requiring prolonged mechanical circulatory support. Although this technique may appear modern, its concept is far from new. In fact, the earliest generations of intra-aortic balloon pump devices were implanted surgically through direct cannulation of the ascending or descending aorta, before the percutaneous femoral approach became standard practice. The axillary approach provides a valuable alternative to the traditional femoral route, particularly in patients with severe peripheral arterial disease, iliofemoral occlusions, or extensive atherosclerosis that precludes safe femoral access. By utilizing the axillary or subclavian artery, clinicians can offer circulatory support to patients in whom conventional percutaneous insertion is contraindicated. Moreover, one of the main advantages of the axillary technique is the potential for early patient mobilization. Since the catheter exits in the upper thoracic region rather than the groin, patients can ambulate and participate in rehabilitation while maintaining Iabp support. This feature is especially beneficial in candidates for heart transplantation or durable left ventricular assist devices, where physical conditioning and preservation of peripheral cannulation are critical to optimize post-transplant outcomes. The technique can be performed through a surgical cut-down or, in some centers, a percutaneous approach under fluoroscopic and ultrasound guidance. Despite its advantages, the axillary route presents certain limitations and risks. Potential complications include local bleeding, hematoma, limb ischemia, nerve injury, infection at the insertion site, and difficulties in achieving precise balloon positioning due to arterial tortuosity. From a hemodynamic standpoint, the performance of the Iabp via axillary insertion is equivalent to that of the femoral route, providing the same diastolic augmentation and afterload reduction. The other widely adopted off-label indication for the intra-aortic balloon pump is its use as a left ventricular unloading strategy during veno-arterial ECMO support. Although the intra-aortic balloon pump was not originally designed for use in combination with veno-arterial ECMO, its off-label application in this setting has gained increasing interest. One of the main physiological challenges during ECMO support is left ventricular distension. The retrograde flow generated by the ECMO circuit increases afterload, impeding left ventricle ejection, raising end diastolic pressure, promoting pulmonary congestion, and impairing myocardial recovery. The intra-aortic balloon pump, through its cyclical inflation and deflation, can obtain partial unloading in this setting. It is important to note that this indication remains off-label and is not included in the manufacturer's instructions for use. Therefore, clinical judgment and institutional experience are essential when considering Iabp placement during veno-arterial ECMO.
If you've enjoyed our video, please press the like button and subscribe to support us so we can continue creating quality content like this.